problem. Today we're going to talk about scoliosis, and joining me is Dr. Mark Willits. He's with the Children's Hospital of St. Francis Health System. Let's jump in, Doctor.
Wonderful.
Now, you are also a pediatric orthopedist.
Yes.
Now, tell us about what is an orthopedist, and the pediatric part, and kind of the range of clientele you deal with as far as age. Tell us about that for those that want to become one.
Okay, sure. Pediatric orthopedics is a subspecialty out of the orthopedic field. There are 13 subspecialties in orthopedics, and pediatrics is one of them. In order to become a pediatric orthopedic surgeon, you go through 4 years of college, getting a 4-year degree, bachelor's in anything really that you want, as long as you can meet the requirements to apply for medical school. Then you go through medical school, which is 4 years. Then you attend a general orthopedic residency program for 5 years.
Wow.
And during that time frame, you have to do 6 months minimum of pediatric orthopedic training. And then to become a pediatric ortho specialist, you do another year of fellowship beyond that, and then finally you're out into practice. So it's a rather long road to become a pediatric orthopedic surgeon. The patient population that I deal with goes basically from birth to about 18 years of age. And that covers a myriad of conditions in kids, including a lot of syndromes and deformities. One of the major ones is spinal deformities of all different types, hip problems in kids, foot problems in kids, dwarfisms, and kids with spina bifida and cerebral palsy, and as well as kids who unfortunately have trauma incidences, riding bikes or being in cars or falls.
Okay. So. Now let me ask this question, because you did mention, from birth, what kinds of, because people may wonder, well, what kinds of conditions could an infant possibly have? I mean, what things do you see? I know the spina bifidas and things, but tell us, what kind of things do you see?
The major things that we see at birth are a lot of hip problems and a lot of foot problems. We see kids with what is called developmental dysplasia of the hip, where for some reason in utero they were in a particular position, like a breech position, or there's a family history of hip problems and the child will be born with a hip condition that potentially requires treatment from early on to allow the hip to finish forming. The problem is that it doesn't form completely in utero. Other problems are those of clubfoot problems, where due to various positions in utero and conditions, the child will be born with a foot deformity called a clubfoot that would require early casting and treatments, possible surgery from early on. We always joke that with club feet, the best time to start treating it is actually in utero if we could, because we want to get to them as quickly as we can, and so we'll start casting these kids in their first week or so of life, and to try to correct the deformity, and we have a very good success rate now with cast treatment compared to doing the old-fashioned surgical treatments that were done. Other things that we see in kids, of course, are more syndromic conditions. We see kids born with conditions like arthrogryposis, where they have problems with stiffness in their tissues and have problems with joint motion and deformities. And we see kids born with congenital scoliosis, which is actually takes place early on in utero, where you get a malformation or what we call failures of formation or segmentation of the spine. So they're born with abnormal vertebrae that cause the spine to grow asymmetrically from a very young age. So,
well, we're going to get more specifically into scoliosis. I do want to ask this, since you're with Children's Hospital with the St. Francis Health System, tell people in terms of the range of services. I mean, you're a pediatric orthopedist, but in terms of the Children's Hospital, do they see kids in terms of cancers or different types of things, or is it, some people may think, well, it's only orthopedic?
Right. Actually, they see a myriad of conditions. We have pediatric general surgery to deal with kids who have problems from a general surgery standpoint. They may have an appendicitis, and they have a problem with their gallbladder or other general problems. We have pediatric pulmonologist who deals with kids with cystic fibrosis, asthma, those types of pulmonary and other myriad of pulmonary conditions. We have pediatric infectious disease physician who deals with kids with different infections throughout the body, including those that involve bone and muscle and tendons and ligaments, but also other types of infections, more exotic infections. We have a myriad of pediatric hospitalists who, when kids are admitted to the hospital, that take care of all their other medical needs. It's basically an internal medicine specialist for a child.
Okay.
And so the myriad of services at the Children's Hospital is providing now, just being early on, and it's really in its infancy of a few years in existence, is really rather remarkable of what's taken place. So I've just recently come onto the hospital as of August 1st, and I am the only full-time pediatric orthopedic in eastern Oklahoma.
Wow.
And so the need in the community has been tremendous, and the response to my arrival has been very gracious. The community, the medical community, has embraced me and has been very supportive of me from day one coming in. So it's
awesome.
a great position to be in, to work with the Children's Hospital. It's a fabulous organization. So.
Awesome. Well, thank you for helping us understand the range of services that are truly, truly available there. Now, I want to focus on scoliosis. Tell us, sort of in general, what is scoliosis? And then, is it really a big problem? I mean, is it like a rare thing or pretty common?
Okay.
Help us understand that part.
Well, scoliosis is, most people think scoliosis is basically a curvature of the spine, and that is a basic definition. Scoliosis itself is actually a three-dimensional deformity of the spine that involves not only a sideward curvature, but also rotational components to the spine, in which it grows abnormally. There is a genetic predisposition for scoliosis, so that if you are a mother or a father who has had scoliosis, your children are at an increased risk for developing scoliosis.
Okay.
There are many different types. The most common type of scoliosis is what we call idiopathic, meaning we don't really understand the etiology of it. We just know that it's genetically transmitted. We're still doing research, and have done a lot of research to figure out what gene markers or DNA markers are involved with of transmitting this condition. But it is a fairly prevalent condition. If you look at children in the general population, about 3% of children have measurable curves that are diagnosed as scoliosis, meaning on a spinal x-ray we measure 10 degrees or more, and that is defined as scoliosis. Out of that 3% of kids, there's about 0.1 to 0.3% who go on to need actual surgical intervention or brace treatment for scoliosis. So the vast majority of kids with scoliosis don't need anything serious as far as their condition and their treatment, but we don't have a crystal ball yet to be able to do one specific test to say that this child is not going to develop a curve that is of surgical need or brace need versus this child who will not.
Okay.
So
let me ask you a couple questions. Number one, on the genetic component, you talked about it, if the parents have scoliosis. What if they don't, but you remembered there was a grandparent or an aunt or somebody way back? I mean, people might say, surely that couldn't be a risk factor for me.
Right. It is still a risk factor, but not as great as a primary person in your family, or relationship, meaning a sibling or a parent.
Okay.
Those who are, when you start taking those second steps back, aunts, uncles, cousins, grandparents, those are that second removed, position, then the genetic influence is not as great in those cases. If you are a mother who has scoliosis, and you have a daughter, we know that there's about a 30% risk of that daughter developing scoliosis.
Okay.
We also know that any sons have about a 12% risk of developing scoliosis based on genetic history.
Okay, we're going to take a really good break, and I'm going to come back and pick up on that sons and daughters distinction.
Yeah.
Okay. Please stay with us. We'll be right back. welcome back to continue our discussion on scoliosis. Joining me again, Dr. Mark Willits. He's with Children's Hospital at St. Francis Health System. Let's jump in now. As promised, I want to get back to this because I know other people picked up on this. You said if the mom had scoliosis, in terms of looking at it genetically, the daughter would have about a 30% risk, correct? But the son only 12.
Yes.
Well, why? They came from the same mom, Doc. Come on.
Right. Well, for reasons that we're not quite sure of, scoliosis is a more female-dominated condition. If you look at curves that are diagnosable as scoliosis at 10 degrees, the ratio of male to female is basically 1:1. But if you look at 20-degree curves, the ratio is 6:1 female to male. If you look at 30-degree curves, it is 11:1 female to female. And if you look at those that go on to need surgical intervention, it's 8:1. So we know that it's a female-dominated condition. So, and most of the studies that we've done over, over time, have been related to females because it's such a female-dominated condition.
Okay. Well, let me ask you another question. I tell you, we just can't cop a break, I tell you. Let me ask this other question in terms of, you talked about there's a certain percentage of kids who would not maybe need correction. We don't know who that would or would not be. But people may wonder, well, do they just correct on their own? I mean, do they start sitting up straighter, or do they start, how do they correct? Or is it so small that you just don't really see much of a problem with it?
Right. Smaller, most curves stay relatively small, meaning less than 20 degrees if it's diagnosable as scoliosis. Those curves are structural and they will be there for life. But that magnitude of curvature does not cause any health problems later on in life. It doesn't cause problems with pulmonary function or breathing or heart problems. Doesn't cause them an increased risk of back pain or functional deficits. They basically have an unrestricted life with no, we don't place any restrictions on them. We allow them to do everything.
So parents may wonder if that's one of my kids has that type. Like you said, there are no restrictions. So playing contact sports, sometimes we think that could be a greater risk of a problem. But playing contact sports or things like that, there's no concern.
No, there's no concern for those kids. We've shown that there's no increased risk of injury, and also we know that there isn't anything specifically that the child can do activity-wise that's going to cause them to further the development of their spinal curvature. Not even carrying a heavy book bag on their back will cause it to increase. I always get that question by parents. So it really is, scoliosis really has a mind of its own, and it's going to do what it's going to do. There's not much we can do to prevent it from progressing on its own, and there's nothing we can really do to make it go away.
Okay, let me ask this question then, because you talked about the development in utero. Are there tests that you do, or that if the mom has scoliosis, that you can do while the child is in utero to see if they're going to have a problem, or people want to know that, or is it once they're born, then you do the assessment and see? How does it tend to work?
With congenital scoliosis, which is actually a malformation of the vertebrae, that is in utero, that is similar to a lot of other conditions like clubfoot or spina bifida, with the very kind of high definition ultrasounds and specific anatomical ultrasounds that can be done. You can actually detect a spinal condition on ultrasound. But other conditions beyond that, as far as what we call the idiopathic types, those are found really after birth. There's no detectable malformation in the vertebrae that can be seen in utero with an ultrasound. And those curves normally develop after birth. It's rare that a kid with idiopathic scoliosis will be born with a curvature that's noticeable. Most of those curvatures will not begin to develop until a kid gets more up towards 10, 11, 12 months of age. And if they develop a curve at age 3 years of age or younger, that's what we call an infantile idiopathic curvature. So,
well, is that something that a mom should ask for if she has scoliosis, to have this ultrasound, or it really is not needed, or what triggers a need?
Yeah, it's really not needed to get an ultrasound specifically if the mother had scoliosis, because it's not a 100% transmission. Okay. And since most of the scoliosis is idiopathic with no deformities in the vertebrae, a lot of ultrasounds would be done that would not show anything. So it's more of watching the child after birth and having primary care physicians, the pediatricians, being diligent in their well baby checkups, to not only checking their their heart and their lungs, making sure they're getting their shots, but also making sure that they're doing diligent examinations of their feet, their hips, their legs, and their back.
Okay, let me ask you on the exam part, because I do want to end up getting into the treatment. I mean, if you do have to do surgery, what does that look like? How should we check, or should we as the caregiver or parent be checking our children for scoliosis? I know people often remember bend over,
right.
But sometimes they're not looking or knowing what they're bending over for. I mean, so tell us about the exam that we as the lay population should do, and then is your exam any different in terms of that observational?
Right. Well, a lot of early scoliosis is it's hard to detect because the curves are small and there aren't a lot of outward physical signs on examination of her curvature. So most of the time when you see something physically on examination, such as the shoulders not being quite symmetrical, one's higher than the other, or the rib cage being slightly asymmetric with one side being more prominent than the other, or the hips not being quite equal, seeing a little shift in the waistline, those curvatures are normally a little bit bigger and more noticeable. It's not uncommon for a child to come in and see me on initial visit with a 25 or 30 degree curvature because parents just don't see their kids like they do when they're 5-6 years in age and younger. Once your kid gets older and becomes more self-sufficient and is taking baths on their own and getting themselves dressed, things will not be noticed. And I have a lot of parents who feel guilty that their daughter is 13 years of age and has a 30-degree curvature, and they just can't believe that they could have missed something like that. And I try to reassure them that it's not their fault and that they're not a bad parent. But examinations, they still do some exams in the school system where they have them bend forward. The nurses are looking for that asymmetry in the chest wall or in the muscles in the back that may lead to them thinking, well, there might be a curvature and we need to get this investigated. That's just a similar thing when it comes to parents at home and trying to look after them and check them. So
especially once the kids, like you say, get self-sufficient, is that something that we should do? And if we do, is it like once a year, or is it like once every 6 months? Does the curve get bad really quickly? And can you do it with their shirt on, or do you need to feel, or do you take the shirt off? I mean, what should we do?
Well, the best examination is for them to not have a shirt on or clothing on their torso, so that you can see their entire back and shoulders. So if a mother is going to examine her daughter and have her lean forward and look and see if there's anything that looks off, they just need to do it in private so they can see. But if there's a history of scoliosis in the family, there definitely needs to be, I think, a yearly examination as the child approaches that pre-adolescent years, because that's the most common time when scoliosis comes on. We always talk about kids who are very young getting scoliosis that are 1-2 years of age or 6-7 years of age, because those can be extremely devastating early on. But the most common types are those that come on when the child is 10, 11, 12 years of age and begins to develop what we call an adolescent curvature. And it's just nice to be diligent and to be watchful as a parent, especially if you know there's a known history of scoliosis in the family. And the pediatrician should know about that history, so that on examination they're being extra diligent about looking at the possibility of development as the child begins to go into their adolescent years.
Okay, well, we're going to take another quick break and have a couple questions to ask on that one. And then I also want to get into treatment, like how do you help correct? Okay, please stay with us. We'll be right back.
Learning how to kickflip 6 stairs takes determination. So will getting into college. I've got what it takes. So do you.
Welcome back to complete our discussion talking about scoliosis. Joining me again, Dr. Mark Willits. He's with Children's Hospital with St. Francis Health System. Let's jump in. Now, I do want to ask this because as parents or caregivers, we are very easy to feel that it's something we did wrong when it's not necessarily our fault for certain things. But complaints or concerns, would the child who's having a significant curvature develop, would they start saying certain things, you know, like my back hurts, or every time I carry my backpack on a certain side, it kind of hurts, or when I wake up or during sleep, there's a pain someplace? I mean, would there be certain things that maybe we could key in on symptoms that they may say?
Unfortunately, no. Scoliosis is not known to cause an increased incidence of back pain or back difficulties. The main complaints that parents will get, or that the daughter will eventually complain and say, my waist doesn't look right, one of my hips looks higher, or one of my shoulders is higher and I don't know why. And a lot of things that will come up will be they'll go to the swimming pool in the summer. Like last summer, they didn't notice any type of condition or problems with the waist or the shoulders, and they'll go to the pool the next summer and she has on her new, you know, two-piece bathing suit or one piece, and the mother will see her walk away, their child, and go, oh no, something's not looking right, and that'll stem them to come into the physician to be checked. So.
Okay, so nothing like that. But once again, the yearly assessment by your pediatrician or you, especially if there's a history, is a good thing, as well as what the schools may do.
Yes.
Now, let me ask about treatment then. Okay, how severe does the curvature have to be before there is an intervention, and what do you do at what levels? Where bracing is appropriate, surgery? Tell us about that.
Right. Curves that are between 10 and 25 degrees, we basically observe those curves because we know that the majority of those curves do not go on to develop any type of intervention, bracing, or surgery. And most kids stall out with curves, 20 degrees or below. Those kids who go on to show that their curves are more progressive and get to 25 degrees or more and still have adequate growth remaining, we can put them into a brace to treat their curvature, and we brace curves pretty much from 25 to about 45 degrees. Once they go into a brace, they keep that brace on until they reach skeletal maturity. So for girls, that's somewhere around 14 and a half to 15 years of age, and we look at their menstrual history, we look at their growth plates, basically, and we look at their overall height changes that they have as they grow, and we can see as we make their height measurements that their growth is slowing down and basically stalling out. So that gives us an idea of when we can bring them out of a brace. As far as surgical intervention...
Well, let me stop you just
Yes.
real quick, Doc, on the brace part. Is this something that the child is in 24/7? I mean, because it sounds like it could be a few years that you're in that. And does the brace change? And is it all the time, or can you take it off to... of course, to bathe or something like that, but otherwise it's on? I mean, how extensive is this brace?
It depends on the curvature itself.
Okay.
Most curvatures require full-time bracing, meaning that the child is wearing the brace 21 or 22 hours a day. So they're actually sleeping in it and wearing it all day and basically taking it off for hygiene reasons. Some kids, if they're in a swimming class or something 1 hour a day or a few times a week, they'll come out for that hour or two to do their swimming class, or girls to do their gymnastics class. But we try to make sure that they maintain wearing a brace a minimum of 21 hours because we do know the effectiveness of the brace depends, it's dose dependent. So the more time they're in the brace, the better chance it has of being effective.
Okay, wow. Okay, now if they have to have surgery, what does that look like?
Well, surgery happens once the curves usually reach about 45 degrees to 50 degrees. The main reason why we do surgery at that point is that we know, based on our studies, that once a curve reaches that magnitude, they will continue to progress into adulthood. So even if the child is skeletally mature and done growing, we know that those curves have a tendency to progress a couple of degrees per year. So if you have a 15-year-old that has a 45-degree curve and all of a sudden they're 45 and they've been progressing at a couple degrees per year, you can see how you can add on 40, 50, 60 degrees onto a curvature and wind up with a very severe deformity that will cause a decrease in pulmonary function over time. We do know that that happens. So we intervene with surgery to basically do a spinal fusion of the levels of the curvature in order to control it, to stop the curve from progressing, number one, and number two, to actually get correction of the curvature. We actually take what the spine will give us, is what we say in the field, is that a lot of curves are very flexible even though we have curvatures. And so when we go in to do the fusions, we can actually decrease the amount of curvature that the child has and decrease their overall external appearance and their deformity with the surgery.
Okay. Now with correction, etc., can the person engage in sports and things like that they're interested in, or does there become a limitation because there's this fusion here and this susceptibility?
Right. It depends on the extent of the operation. In girls or guys who have limited curvatures to more of the upper spine region where the rib cage is, what's called the thoracic region of the spine. A lot of times we can do isolated operations over maybe only 5 or 6 levels of the spine, maybe 7 levels. Those isolated fusions in that region leave all the major motion segments of the spine alone. Those are really the lumbar region that are most responsible for the majority of our movement. So I have females who are in gymnastics who do a lot of tumbling and come off the balance beam or dive after balls and volleyball who continue to participate in those sports although they've had a fusion because they've had an isolated operation. Those that are more extensive that involve thoracic and lumbar regions take away a tremendous amount of motion in the spine, unfortunately. So there are more lifelong restrictions with those operations. And so we try to steer them towards doing other sports that are non-contact or that don't involve doing tumbling and those types of things. So we encourage them to do swimming, to do running, to do maybe soccer, get into golf, those types of things that will not cause potential harm.
Okay. Well, thank you so much for that understanding, and we know what to do and what to look for. Thank you so much, Doctor.
Appreciate it.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/healthalertusa. And remember, look at your child, get those assessments done by your pediatrician. Don't be afraid to ask them, can you just check, especially as they get older, and get the care that your child needs. Take care.